I can start the call like this if you want.
Yeah, yeah, yeah. So everyone sees this picture of Kyle with his arm cut off. Um, Kyle, you'll have to hold your arm up for the entire webinar so that people can tell that that's you. Um, so on that note, welcome to our brown bag. This is diabetes care around the world. For those who are joining us for the first time, DPAC is the Diabetes Patient Advocacy Coalition. We are a coalition of patient advocates who work to advance policy on the state and federal levels. We train people on how to advocate, we keep them updated on developments that happen in policy, and we provide avenues to take action. So Brown Bags are our webinar series, and we cover a variety of topics, which you can find on our website and on our YouTube channel. Clips of this we will also be posting on social media, which are listed on the bottom right corner of the graphic you see. So without further ado, here are our speakers for today. We have Megan, who is a DPAC champion, Emma, the Global Policy and Advocacy Manager for Life for a Child, Jackie, President of DIALEV and Vice President of the International Diabetes Federation. And Jackie actually joined us on Capitol Hill recently for our 2025 Hill Day. So you might have seen her in some of our pictures. And lastly, Kyle, who is also Vice President of the International Diabetes Federation and also a dedicated member of the DPAC Champion Corps. So we are so lucky and excited to speak with all four of you. Thank you for being here. Let me stop sharing and then you can get
Thank you.
questions. So my first question is, can each of you share where in the world you or your loved one needed care outside of the current US system? And if you are comfortable, what brought or sent you there?
Should I start?
Anyone
Yes.
can start.
Okay. I'm currently based in Beirut, Lebanon. I'm Lebanese, and this is where I started Dialab. But just for information, Dialab is also registered in the US. So that's why I was part of the Hell Day with DPAC, and it was an amazing experience. And whenever I am there or here, I like to believe that I'm a strong voice and advocate for every single person living with diabetes in the globe, wherever they are. And that's it. Megan, I'll pass it to you.
Yes. So I'm honored to be here amongst these experts. Our journey with diabetes started just last year in Bermuda. So I live in the United States, and we were vacationing on a cruise and in Bermuda when my daughter needed to receive care.
I'll go next. So my name is Emma. Thank you for the introduction, Amanda, and just wonderful to be here with these experts and happy to call some of them friends and hopefully all of us friends by the end of the webinar. But I live in the UK. I live with type 1 diabetes. I have done most of my life that I can remember. But I was brought up in the US in Los Angeles, and I moved to the UK when I was doing my master's degree. So have experience navigating at least a couple of health systems with type 1.
Last but not least.
Hello, everyone. Lovely to join this panel with friends and colleagues. And I have been back and forth between the US and Europe most of my life, France in particular. So I'll be sharing experiences of living with diabetes in France. I had type 1 diabetes since I was a teenager. And I'm also a part-time caregiver for my mother who lives with type 1 diabetes, who's in her 80s. You may remember if you have joined the previous session that I participated in with Deepak.
Yeah, that was over a year ago now, huh? So what were your diabetes needs at the time of receiving care in your respective countries? Your or your loved ones?
Hmm. Amanda, would you like to name the person who you want to speak, or should we take it casually?
We can do we can do the same order that we did for the first question if you'd like.
Well, I will start again for this time only. So, My daughter Sylvie was diagnosed. We were already in Lebanon. She was at the age of 24, and she was engaged to be married. And her diagnosis came to me as a mother as the biggest shock of my life because I wasn't confident of any information about diabetes. And this ignorance, let me say, made me feel insecure, afraid, terrified, like the whole world was collapsing. Luckily, she was very mature in handling the news, and she was the one who gave me strength. Now, in relation to the care, again, we were in Lebanon. She had lived in the US, and she had participated in several things on the Hill, sometimes with ADA or other small groups. And she was receiving very good care at that time. But again, because you can afford it or your insurance could cover some of it. In Lebanon, it's technically completely out of pocket. But then after that, and in an article she published lately, she mentions that one of the reasons why she moved to Qatar was that the healthcare for diabetes was fully covered and she had a good job opportunity. So we're talking here about the difference between Lebanon that relies mainly on out of pocket. Certain things are covered, but we've had so many problems, economic collapse, devaluation, unprecedented devaluation, I should say. And in some point after the Beirut blast, we had shortage in supplies and shortage in electrical power. So the storage was an issue, not just the availability. Whereas all of that is not an issue in Qatar or maybe in the US. The availability is there, the power is there. So sometimes when I speak about those challenges, I see on the faces of people like, what? You need to think how to store insulin? Yes, it can be sometimes an issue when you live in a country with a lot of conflicts, surrounding countries in conflicts, part of Lebanon being bombarded, and so many other things. So in some cases, I know friends, family friends, used to travel to get their supplies either because they were cheaper or because of that they needed to see couple specialists and that would cost a lot of money before they would get their prescription. So for multiple reasons, they would travel and get their supplies from neighboring countries. And nowadays, I feel the struggle of people living with diabetes because of all these issues. Sometimes availability, affordability always, shortage in supplies, and we will talk more as we progress. So I leave the chance to my other partners on the panel to speak.
Follow the order from last time and go next. So for my daughter, we were in Bermuda for a relatively limited period of time. So the time was short, but arguably the most important diabetes care that she's received. She became very ill when we were on a cruise ship. And so she was initially diagnosed actually on the cruise ship, and then we were transported to the hospital once we docked in Bermuda. So she was, initially she was in diabetic ketoacidosis, so needed stabilization and treatment. And then following that, we needed the education to manage her new diagnosis. So learning about insulin administration, diet considerations, managing her glucose levels. It was a bit of a whirlwind, but really happy for the care that we got on, both on the cruise ship and in Bermuda.
Yes, and from my side, I just preface all of this by saying I grew up in the States, but I moved to the UK in my early 20s, and so I must say that despite my experience as a young person living with diabetes in the US, and I was actually the national youth advocate for the American Diabetes Association back in, I don't know, I think 2003 or 2004. But despite that experience I had, that was very much at a high level. And I didn't really have the lived experience at the nitty-gritty navigating insurance level because my parents protected me from ever having to face the administrative burden of living with type 1 diabetes, living with diabetes or any non-communicable disease in general. And I think that's something that, you know, they're it's tough enough to manage a chronic condition, but that administrative burden alongside the difficulties in life managing a chronic disease, even death, the administrative side of things, nothing and nobody really prepares you for that. But fortunately, in the US, I didn't really ever have to kind of look into the eye of the needle of the administrative burden. So when I moved to the UK, I was young, but still an impressionable adult. And really, the UK was where I kind of learned about the administrative side of things. And, I must count myself as extremely blessed to have found myself as a young person living with diabetes in a country where, by and large, the exposure to potential catastrophic medical expenditure is largely protected by the public system here in the UK. I've never had to worry about accessing affordably the tools that I continue to access: pumps, test strips, insulin. Everything that is prescribed to me, I've never had to worry about affording. Now, technology and keeping up with how technology and diabetes management has changed, that's another part of the equation, because the UK and its public health system did not always provide coverage for CGMs and AIDs. So there was definitely a time where, I was fortunate to be able to pay out of my own pocket for my CGM supplies, and I did that for a few years until the NHS was able to provide that equitably for the type 1 diabetes population. So it's a mixed bag, and I'll say that no health system is perfect. Each one has their flaws, but I'm sure we'll get into more on that later.
Yeah, my experience was similar to Emma's. I think there are probably some strong comparisons that could be made between the NHS and the Sécurité Sociale in France. So I was very fortunate that I had access to everything that I needed. And at the time, that was included an insulin pump. CGMs hadn't quite been approved for reimbursement. I know we'll get into kind of some of those details later on in the panel, but for me, it was insulin pump, test strips, insulin, and then the care that I would need from medical professionals, all of which was covered with the affection longue durée, the chronic disease coverage in France. And to clarify, the reason I was there is because of my father's work. So we were back and forth between the two continents because of his work. So I got to experience living with diabetes in both, and I was there long enough to the point that Megan had made, that I really needed to establish myself within the healthcare system each time I went back to benefit from those, or to assume those benefits, I suppose. Yeah, that's all for me. And then I know we'll get into it with the next round of questions.
Yeah, we are. I am going to ask about CGM's insurance coverage, all of that. But quickly, I wanted to ask before that, what stood out to each of you about the healthcare that you or your loved one received in that country? Or if you moved to the US later in life, what stood out to you about the US?
I can start this round. So we hadn't received diabetes healthcare until we were in cruise in Bermuda. But when I had the opportunity to compare the two, I would say the bigger differences that I saw were really likely driven by the location and the size of the population. So Bermuda being a small self-governed British territory with a relatively small population. Boston, within the city limits, has a population about 10 times the size of Bermuda. So when we received care in Bermuda, we were in the the pediatric unit in the hospital. There was a pediatrician that came to see us, but we did not see an endocrinologist there. And the care that we were able to receive in Boston, just with the population, the number of hospitals and the specialists, it was much more specialized care. When people that are working with children with type 1 diabetes day in and day out. I would say that the care in Bermuda, just from the few days that we were there and then some experiences that we had after too, definitely we saw the strong sense of community, the Bermuda Diabetes Association being really involved. That we had a diabetes educator that came to visit us and help us with the training. Everyone was working really hard to make sure that we could receive all of the training we needed to be safe to take the cruise back to Boston. And then they, really, really cared for us there. And, I was receiving texts from the pediatrician on our cab ride back to the boat to make sure we made it on time. Just the kind of sense of community and belonging was quite strong there, real, personal care situation, which was great. But of course, they don't have the population. I don't know that they do have a pediatric endocrinologist on the island. They do have some endocrinologists, but it is, relatively limited what they're able to provide.
I think I'd just say from my, oh, sorry. I think
No,
I'd
I
just say,
wanted to say you go or Kyle.
oh, thank you. Yeah, we're switching up the order. Feels like a bit like roulette, who will go next. But I'd just kind of briefly say from my experience, and just a disclaimer that, I feel so fortunate working for Life for a Child. I'm not sure if your listeners will be familiar, but in some ways, I kind of feel like I live a double life with diabetes because, on the one hand, for me, myself, and my own management, I've always felt blessed, and I've always been very fortunate. The US has its serious challenges around delivering equitable diabetes care. The UK, financially, there's always that protection for patients, but in the UK, it's not. I think that, Megan, you touched on the sense of community and that passion. And I think, I can only speak from my experience that I've missed that so much in my care, the passion and the sense of, honestly, the connection between endocrinologist and patient. That's something I miss tremendously. I was fortunate enough to have, honestly, I could describe it as a very loving, a very caring relationship I had with my pediatric endocrinologist growing up. The uh, hard to describe Dr. Francine Kaufman was my endocrinologist, and it's hard to find someone quite like her. But I think that that passion and that connection is something that I always kind of associate the US healthcare system with in type 1 diabetes. If you are fortunate enough to be able to have, good enough insurance to be connected to an incredible physician. But, back to the thing I was saying about the double life, I have my own personal experience with it, but every day in my work is around the realities of healthcare systems, or lack of systems, really, that provide both that level of protection and organization of care for young people with diabetes. But one thing, Megan, that you brought up, sometimes it's not, you can have you can have the passion and the care and the connectivity and the love really in the care that's provided, despite the limitations in the healthcare system. I think people are the most important part of care. It's all about the people. So just say that.
Your comments really resonated with me, Emma. I think, a number of us on this call are working for organizations doing work internationally. And for me, that work with International Diabetes Federation has made me very much aware of how incredibly fortunate I am to have access to the medicines and care that my system provides for me, whether it be back in France or in the States. So I think, to answer the question, for me, what really stands out about healthcare in France is it's the price, it's the sticker tag. It's not You're not worrying about that when you are in a medical situation, whether you're going to the hospital for an emergency or thinking about care more broadly with a chronic disease. Whereas in my life in the US, certainly, worrying about having medical insurance is constantly on our minds as people with chronic disease, with type 1 diabetes in my case. And how could it not be, right? I mean, we have seen the stories, and some of us have even faced these sticker tags, for lack of a better word, on insulin or other medicines or technology that just are completely inaccessible. And then depending on the insurance that you have or don't have access to, then this is a big factor in the equation. So I think, yeah, and I know maybe we'll be getting into cultural norms later on in the panel, but in France, certainly when you're inscribed in the Sécurité Sociale, which is everyone in the country, you have the expectation that your care will be paid for. And with the affection longue durée, a chronic disease patient, it is covered at 100% in the case of diabetes, whether it be a visit with the endocrinologist or picking up a medicine at the pharmacy. So for me, that's clearly what stood out, and a stark contrast with healthcare in the United States.
Well, listening to all three of you, Megan, Emma, and Kyle, I want to tell you that you are very fortunate to be living where you are, be it France, Europe, or the US, because I'm on my second term with the International Diabetes Federation. I am currently also on the board of the NCD Alliance, and I have been a consultant with WHO on a couple projects. And living in Lebanon has made me see such a difference, such a different face to diabetes and the needs of people and the settings, humanitarian crisis, economic crisis, which is nothing like what you are describing. But on the other hand, if I had to mention something that stood out for Sylvie and myself, that in Lebanon there is a very strong commitment and personal connection, much easier than we could find in the US. But on the other hand, we lack somehow a structured diabetes self-management education and support programs. But in the US, I could see a better formal access to technology, through insurance channels, but yet what could be a barrier is the bureaucracy, the prior authorization, sometimes high out-of-pocket costs. So, like I could say briefly, like every part of the world would have some challenges. There is no such thing as la vie en rose, as you would say, Kyle, in France, for people living with diabetes, because even in the most secure places where everything is covered, we have to remember that the challenges are not only access, they can be the mental burden of the so many decisions, and you are living with it, you know better than me. I speak poetry maybe, but you are living in the condition, Emma and Kyle. And I know if Sylvie were here in my place, she would also describe it much better. But I've seen a lot of cases, and it's unfortunate to see in the low middle income countries how much there is of lack of access. And this is speaking of the basic necessities like insulin, like basic needs. When you speak about CGMs that you mentioned earlier, this is a completely other story. Nothing covers it. It's 100% out of pocket, and the price is not even close to affordable, where people have to buy the sensors with the two packs for, in Lebanon, I think it's $77, and it can barely, if it works, the 14 days that they say it should, it's 28 days. It's not even a full month. So really, on top of the price of insulin, the doctor's visits, the regular checkups, it's a huge burden. So sometimes people skip doctor's visit for that specific reasons. But again, one good thing I could say about the system in Lebanon is this personal connection. I know from Sylvie that she sends a WhatsApp from Qatar to her doctor in Lebanon whenever she feels she needs reassurance, sometimes just to feel this is okay what is happening or whatever, although she might have consulted another endocrinologist there, and she has her endocrinologist there. So this feeling of feeling secure, I think, is very strong, and I've heard it from people in our group, people living with type 1 diabetes in our dialab group, that they have this feeling. But of course, the challenges are huge.
Thank you. Yeah. So on the topic of accessibility, how did coverage for diabetes technology and medications work? And what, in your experience, all of your experiences, were the main barriers to accessing any specific needs? And I'm actually going to combine this with our next question, since it's two sides of the same coin. What diabetes technologies were most commonly used in the region where you have experience, and why do you think that is?
Just if I may go first on this one, I mentioned something in the last question you asked, Amanda, about feeling like living a double life. And I think a lot of people who work in the global diabetes advocacy space kind of deal with this duality. And I think, for me personally, it's been quite difficult to when thinking about access to technologies and what is reimbursed and how are health systems structured to protect patients, financially from these out-of-pocket burdens, which quite frankly is a matter of death in low and middle income countries. It's been quite hard for me to kind of juxtapose my reality with what Jackie was mentioning about the realities of actually the majority of people globally living with diabetes. But I think something that has helped me is that it's not really a matter of competing hardships. It's not, there isn't this hierarchy of suffering. The issues are real across all settings, yet we have to, go back to what Jackie said, that the consequences differ profoundly. So really, I think, access gaps in Europe, in the UK, in the US, those are serious. But, we must also recognize that in many low and middle income countries, the consequences of limited access to diabetes care really are life or death. So I think there is that spectrum of urgency there that we must consider. So Yeah, and just to sort of answer your recent question in just one or two sentences, um, in LMICs, most insulins, most modern insulins, analog insulins, they're not covered by health system insurance packages. They're not incorporated within national health systems. That is very much the truth, and even more so for blood glucose test strips. We live in a world now, fortunately, where there's really been no better time. Nobody should have to endure diabetes, but fortunately, I think there's no better time to have been diagnosed. If you live in a setting um, where the out-of-pocket costs are low, but test strips even are completely unaffordable for most families that live in settings where the health system's just not designed to protect the rights of those living with type 1 diabetes. And when it comes to CGMs, I mean, you can literally forget about it. And in my own experience in the UK, I have this isn't really related to what I just said, but just touching on my own personal experience, I've seen in real time how a health system is how the needle has been moved within the health system to start providing modernized treatments for diabetes that can make lives so much more dignified. So being part of seeing that journey, I feel very blessed to be part of. And I think, it takes many different types of advocates to move that work forward. It's not just patients, it's all types of stakeholders.
I'm gonna come after Emma because I have something to add here. It's not just the people living with diabetes who can make that change happen, Emma. I just came in November, we had a meeting with parliamentarians from several countries from across the globe, and it's very important to involve policymakers because if we want to see the change happen, if we want it to happen fast, there has to be policy changes. They are the ones who can help us. And the major barrier is that they want to help, but they don't know. So our role to make the change happen and give more access, more affordability, better policies to support the people living with diabetes is to ally ourselves with parliamentarians from our countries. Now, if I want to go back to the coverage for tech, I think I mentioned already that in Lebanon, mostly it is out of pocket. The barriers are mainly the cost and also with the economic collapse and the currency collapse that we had, the affordability of people has dropped tremendously, dramatically. And also with the explosion of the port, the imports are now intermittent. So sometimes there is shortage of supplies, and also the reimbursement system is not functional. This is about Lebanon, whereas I could say about the US, the coverage could vary from one state to the other, from what I know. And also the co-pays and all the bureaucracy, how long it takes, how much it covers. And let me say here that through my connection with the international organizations, I had, let me say, it's an honor to interact with people living with diabetes from across the globe, but sometimes makes you sad to see that when I speak about low middle income countries and I think of Lebanon, and then I go to India and I discover how fortunate are the people living in Lebanon. So Emma mentioned something that the consequences can be very different. and the gaps and the needs and the challenges very different from a teenager or an adult living with type 1 diabetes in Lebanon or in the US or in France or in India, where the story is completely different, or in Kenya, where I know someone there and they tell me about the situation, and I have visited actually. You also asked, combined with the other question that's about the access to
Oh, yes. What technologies are most commonly used?
Okay, so from what I see here in Lebanon, from our group at Dialab, and we do meet frequently, we do support groups, and we do activities together. Few of them use the CGM, those who can afford it, unfortunately, because there's no equity in this at all, and it makes me sad. But rather than us as an NGO thinking to support in that direction, I prefer to see who is in need of insulin. And this is our policy at Dialab, that whenever we can do that, we help people with insulin. So what determines is affordability. And what they are mostly using is the test strips, and those are also expensive. But for us, it's much easier to help supporting the strips rather than the CGM, which is very expensive. And sometimes there are international NGOs that have offices here who support, um, because we don't have a strong health system. And I'm not, I want to say something here. I don't want to blame the government, especially in Lebanon, although I know they can do better. But if you had any idea of the recent years' history in Lebanon, I would say, thank goodness we still have governments, we still have ministries, we are still standing, and the challenges were tremendous. So again, for here for Lebanon, it's the ability to pay of the people is one major challenge. And it's up to some unofficial systems, or let me say additional systems that were created, including us, Dialab. We were not supposed to go into giving insulin or medication. But when you live somewhere where you see the extreme need of the people, we had to do a shift in our policy, do a board meeting, and say, okay, let's try and fundraise and help these people. We cannot close our eyes and not see what's happening around. So I hope it answered, and thank you for the time.
Yeah, thank you. I'm sorry, we're running a little short on time, so I might condense some of our questions. If you don't mind, I might get into the cultural portion of these questions now. I wanted to ask, how do cultural norms or expectations shape the way people manage diabetes where you have experience? And part of that question is also, what role do families and communities play in supporting someone with diabetes? I know we briefly touched on that earlier. And then are there any cultural specific challenges around stigma or misunderstanding?
I can comment on what I was able to see in Bermuda in terms of culture. I mentioned the strong sense of community, and I would echo that for the support of the diabetic population. There, similar to many other regions, there has been an increase in diabetes, and have seen in the news for Bermuda in their increased efforts to combat stigma. From what I was able to see from their diabetes association offerings, I think that's really one of the strong pieces that they're doing to combat the stigma with their education events. They have some mentoring opportunities, so really bringing the community together. for awareness, education, and fundraising. So in terms of, overall support, they do have their own pharmacy as well as delivery to the island. Again, it's a small place, so able to do something like that. But I think that helps to keep the community together, but then also to help with the access for all. So, ideally people are not left behind.
I'm so glad you asked a question about stigma. So Jackie, who I work with, knows that I'm very passionate about this topic. I'm going to do a quick plug, if I can, Amanda, for something called the End Diabetes Stigma Summit that's being driven by Jane Spate and a team out of the Australian Center for Behavioral Research and Diabetes. And that is actually a pledge that has been written that we are asking organizations to think about the language and activities that they do, whether they're employers, schools, whatever that organization may be. And you can find out, I'll put a link on the chat if you're interested. We've had thousands of individuals sign this and hundreds of organizations. There's a consensus statement that's been published, and there'll be a summit next year in India. And we're looking for as much support as we can, because I really do believe that stigma exists in all of the countries that we're speaking about, probably in different shapes or forms. No matter what the healthcare system, how good the healthcare system, I guess, is doing, we do see this stigma, and we see how it impacts people living with diabetes each and every day. And I think tying it into the other questions that you've asked here, Amanda, in France, I would say from a cultural norm perspective, people are a bit more private, in my experience, than Americans about their chronic disease, about medical things, maybe. And so, practically speaking, how does that manifest itself? Here I'm literally wearing my diabetes on my sleeve. I wore short sleeve to show that today, and it's just something I think it's happening more and more, maybe in France, but it wasn't the norm before, and people like to, on average, stay more private about it. And as a result, I think because people are staying a bit more private about it, perhaps it perpetuates more stigma because we kind of live in our own silos. And so there's not as much collaborative discussions going on with medical professionals as well. I often say, and I have a lot of doctors in my family, especially in my in-laws, I say that le docteur sait tout, le docteur est roi, the doctor knows everything in France. And so it's a bit of a one-way discussion. So forgive me to any of the clinicians out there who may be listening, but I think that's changing. But I hope it will continue to change, because I think that can make a big impact on our lives. And also just this whole aspect of psychosocial support, I don't think has been something that the French health system has embraced. You can get an appointment with someone if you'd like to talk about mental health, but it's not kind of one of the things that's included in the system. The great thing about the French system is once something has been included, let's say a technology like an insulin pump, you get a diagnosis as a type 1, and you have access to this system in a relatively straightforward manner. But if it's something that doesn't exist within that approved criteria, then the kind of petitioning mechanism can be quite burdensome. And then maybe just going back, because I missed the last round of questions, in France, there's something called an intermediary company, the prestataire de services de santé, that handles all diabetes technology. And it's kind of unique actually to France, where you actually have I'm not going to mention specific company names, but pump manufacturers don't interact directly, for example, with patients living with diabetes. There's an intermediary that actually handles all of the administration for you. And that is also the case with CGM as well. And so you kind of interact with this company several times per year. You're required to, and it's actually a pretty phenomenal service that's offered. There are they're called field nurses. My wife actually had this role for a while. She's a trained French nurse, where they go to your house twice a year physically, and you have this home care provided, which is pretty phenomenal when you think about it, to interact with you about your using the pump and check that everything's going on. They also check if your insulin vials in the fridge are not expired, and there's certain things that they're required to do. So there's some additional details for you about the system in France.
I would like to jump in. Sorry, Emma, 1 second, because the issue of cultural things being from the Middle East is it's important to show you the difference that I've noticed, and stigma exists in a very strong way in many countries of the region, maybe a little bit less in Lebanon. But I want to first say the role of the families is extremely important. And this is not because I have a daughter living with diabetes. This is my experience with over 100 young people living with type 1 diabetes with whom I interact on a regular basis. And I hear their stories and I see the difference in how they live with diabetes when they have family support versus when there is a different story there. And coming back to the stigma and the blame, sometimes there are still areas, even in Lebanon or in other Arabic countries, where they think about whether somebody living with type 1 diabetes should get married or not, should get employed or not, and concerns about all that, and maybe some kind of blame like, what did you used to eat in order to have gotten to this situation and so on. So this still exists, and the burden of that on the people living with diabetes is tremendous, and it can lead to secrecy, to sometimes dangerous situations if the surrounding doesn't know about that. Sorry, Emma, I cut you. I just had to mention this. Go ahead, please.
Oh, no, thank you, Jackie, for sharing that. This was more of just a personal thing that I've learned. I just passed 26 years living with type 1, and I must say, Kyle, your point around stigma, things when you zoom out, things are changing, and that's why, I'm so grateful for the work of Jane Spade, of Renza Shabilia, and so many others around really leading the charge on global stigma, because 26 years into having diabetes, I feel like I feel the aftershocks, to be quite frank, of the early stigmatizing messages I had societally, even in high income countries, around shame, secrecy, and personal failure to do with diabetes. I think people living with diabetes, like every decision they make has an outcome, and the pressure that people with diabetes are under constantly, it's really no wonder we feel the weight of that personal failure at times. And I think that's being unlearned. And I'll just go back to something I said around I think there's never been a better time to be unfortunately diagnosed with diabetes from a technology medicines perspective, and the way science has evolved, of course. But I think the same thing around stigma. We're finally really talking about it and destigmatizing it, and not standing for perpetuating stigmatizing language any longer, because it affects people with diabetes throughout the life course. It's not just as and when they receive that stigma, it lives within them. And the biggest thing I'm working on right now living with diabetes is unlearning a lot of that, and it's thanks to the community, it's thanks to Kyle, to Jackie, to Megan, to everyone else, that we can have these conversations openly. So thank you all.
Yeah, thank you all for sharing that. It is quite sad from my perspective that the common thread between all of these countries is the stigma, but it is also uplifting to hear us, openly talk about it on this call, and hopefully for the entire diabetes community to be seeing these changes. And so DPAC operates within the US health system and the US government, and we are comprised of people just in the US. And if we want to think more globally, what perspective or takeaway would you want US advocates to remember? And feel free to include things from your own part of the world that you think have worked well. or that you think haven't worked well maybe, and you think US could learn from from watching?
I'll go first on this, but will be brief. Um, I would say the first takeaway that I would like the attendees today to take with them is don't assume that access equals availability, because it is not the case. And let's think beyond coverage and consider the supply chain, because we forget to think about it if we're not from low middle income countries. Um, we need to think about local distribution. We need to think about community networks. And I would invite everyone to invest in very simple and scalable diabetes self-management education and support. I mentioned it earlier because I'm a fan of this support system, which is DSMES. And I would also make a call to support local advocacy coalitions. Um, I want to appreciate what DPAC is doing in the United States, and through people like me outside of the United States as well, because I learned a lot on the 2 days that we went to the Hill, and the preparation before uh, and what came after. So thank you, Deepak, for that. And finally, I would say please prioritize affordability and supply resilience alongside the innovation. Innovation alone is not enough. We need to offer resilience to people in order to get the outcomes we want. And thank you from my side. Thank you for having us. And I will listen to the key takeaways from my panel colleagues.
I can add, basically just with my brief experience with my daughter, and from learning from my colleagues here as well with these with these stories, and really just to be considering that diabetes management is really multifaceted. So considering the healthcare infrastructure, education, cultural practices, so the importance of building community support networks and really advocating for inclusive access, it can make a significant difference. So there's something that each of us can do to help make this better globally.
I guess maybe I think we're coming up to the hour, so I don't know if I'll get this in otherwise. I wanted to highlight an advocacy example in France that really was very effective for tech, and specifically that was CGM. So it was being advocated for more than a decade, I would say, without much results, without many results. And around 2013, the Fédération Française des Diabétiques, the French Diabetes Association, teamed up with stakeholders in different groups, including industry, including the manufacturers, which it doesn't happen as frequently in France as it does, I would say, elsewhere, particularly in the US. And it was pretty remarkable how when all the stakeholders got together, what happened. And basically there was a change in the personnel as far as the policy decision makers. So it was kind of an opportunity, and the advocacy organizations took advantage of this full on with full page advertisements in big newspapers saying, more or less, it's criminal not to have access to this. And again, fortunately, this is within the setting of Western Europe and France, where there were funds in the healthcare system to be able to back it up. And at first, it started with having a limited access to people with only a certain hemoglobin A1C, which was a good first step, but still unfortunate for all of the others. And so I think it was something around 7.5% or 8%. Only those people had access to it. And then the year after, I believe, it was opened up to the rest of people living with insulin-treated diabetes. So it was a big win for advocacy, and people today have access to it in France because of it. So maybe it's a nice example to highlight.
Just give my 2 cents, just just resoundingly agree with Megan and Kyle. This is a melting pot. That a melting pot approach, I think, is one of the most sustainable and long-term ways that we can influence change. I think all of us advocates know that change doesn't happen fast. It happens slowly, but it happens surely. And it feels kind of weird giving advice to any kind of global US advocate because I guess I was one once. Maybe I still am as well. But I think the philosophy that US diabetes advocacy groups have, um, it's very much a model for the rest of the world. That's how I see it. But I guess if there's one thing I would say, I would always urge advocates, be they in the US or anywhere else, to see advocacy really as an invitation and not always like a declarative statement. I think that change happens when communities, clinicians, governmental actors, and industry work together rather than in parallel. I don't think that any single stakeholder is going to fix access to affordable insulin or monitoring technologies. And I think the lesson that I've learned around global advocacy, it's not necessarily always about speaking louder, though sometimes you need to, but more so really rather that it's about creating space, for others to lead and be willing to work inside systems that again move things slowly yet carry it all together.
Thank you so much. And thank you again for everyone for joining us today. I, for one, learned a lot from this panel, and I feel very lucky to have been the one to host it because I'm just sitting here listening to all of your perspectives, and I'm like, wow, like I could have never imagined. I mean, of course, we all have our own small perspectives on, our lives, except for, the few of us who work internationally. But it was very enlightening for me to hear about all of your experiences. And lastly, I just wanted to plug DPAC actually has an action item for our advocates right now. This is completely separate from the brown bag. We're just currently working on the extension of the ACA tax credits. So we are currently asking our advocates to send our pre-written letter to your members of Congress. This enhanced advanced premium tax credit was originally established to make health insurance more affordable for people who received coverage under the ACA. So without them, people will see their premiums rise significantly. And they're set to expire on the 31st of this year. So it is a quite urgent action item, and you will find it on our social media. And if you are already a DPAC champion, you should have received an email on Monday that says action alert. So that is the last thing that I will plug. And thank you again for our entire panel for joining us today. This will be up on YouTube, and it is live streamed onto Facebook as well as our DPAC website. I'll also be posting clips on social media in the coming days.
Thank you, Amanda, and thank you, everyone.
Thank you. Yeah, really enjoyed the discussion. Thank you.
Thanks, everyone. Bye-bye.
Bye.